Hi, everyone. Welcome. The topic today is the patient spectrum, meaning types of different patients, and then strategies to approach such patients. So while I'm mostly going to be talking about matters related to tick-borne infections, to chronic Lyme disease and co-infections, this really applies to chronic complex illness in general, and whether it's mold and metals. I'm looking at the complicated patient where there's layers and layers of illness. Uh, Over the years, many of us have found that every patient is different, of course, and that we can't just, at least I can't, have a one method treats all. That being said, um, there are some patterns that a lot of us like to find, that I like to find, as far as how to manage that sickest group of folks. Uh, Before I get to that order of treatment, rough order of treatment, just like to mention that there are also in rough categories three types of patients. There's the sensitive patients, there's the middle of the road or average patients, and then there's the robust patients who we see, all of whom can be very sick, but the method of treatment for each of them is a little bit different. The sensitive patients are those that can't readily handle most treatments. There's the treatment process is so much geared towards even just getting those folks into the starting gate, into getting ready for the treatment. In the case of tick-borne diseases, getting ready for the killers, getting ready for really moving the needle. So much with sensitive patients is trying to find that way to find a way in. Eric Gordon talks about doing the dance, and the dance of finding the right treatment, finding what the body will tolerate, finding a way to get to that next step is really applicable mostly to the sensitive patients. Um, these folks, sometimes they can't tolerate herbs, they can't tolerate meds. Many of them can't do detox, many of them can't do binders and things like that. So it's really finding out how to decrease that reactivity, and so the sensitive patients can still succeed in their treatment, which many of them can. The middle of the road patients, they can also have very strong reactions to treatments, but they recover fairly rapidly or average to some of those strong reactions. We still have to be careful, but there's a little bit more room for error, for trial and error in these folks. We can often do aggressive treatments, but we have to often work up to it. Whereas with the robust patients, the problem isn't so much that they can tolerate the treatments, it's that the treatments actually work. Oftentimes these folks, now they can still be very, very sick, and they're not necessarily at a significant advantage from an illness standpoint, but from a tolerance of treatment standpoint, the issue more becomes, are you giving enough treatment? Are you giving a broad enough and accurate treatment, and really finding out what we actually need to treat, knowing that people can tolerate so many things and not actually wasting time and money by treating the robust folks with things that don't really move the needle all that much. So that being said, the general order of treatment that I like to follow is eightfold, more or less, with chronic patients. And so not everybody needs this. And again, I am talking about those folks with just layered illness, with something maybe there is not just infection, there's hormonal issues, there's toxicity issues, there's environmental issues, there's trauma issues, there's that folks are very complicated beings, and that sometimes what actually caused that illness to actually manifest, you can't just stop that last thing that broke the camel's back, as it were. You have to go in and work on all of the layers, all of those contributing factors. And so for that group of patients, I find that the best order of treatment is to really calm the system, and then allow things in, which I'll get into in a moment, followed by nourishing the body, restoring immune function, cleaning up the terrain in order to kill the infections, followed by maintaining and sustaining, often with more detox, and then finally changing the model from an illness to a wellness model to actually rejuvenate the system. Okay, so calm the system. The idea is stop inflammation. This category can be very long, but it also can be the most fruitful once we stop the madness, stop the chaos. A patient comes into the office with tons of symptoms, can't tolerate anything, or maybe can but still reacts very significantly. The idea is to calm the system down. There's a lot of models that describe this. There's the nervous system moving someone into parasympathetic dominance from sympathetic dominance, where they're not in the stress, fight, flight mode, but moving them more into a calmer mode. But there's also cellular theories. There's the cell danger response. There's the survival response. There's a lot of different non-nervous system modalities that apply to the treatment of calming the system. Now, the to stop the reactivity, we do want to decrease inflammation, but we do have to find, especially with the sensitive, we have to find that dance. What can somebody tolerate? How can we get them to a place where the treatments actually will stick? Sometimes we have to take really detailed histories. We have to do physical exams. I think that this part of the visit should really, this part of the process should really be person to person, face to face. I mean, we need to find out what modalities can people use. Can they use pharmaceuticals? Can they use supplements? Can they use homeopathics? Do we have to use things that aren't going through the gut? Do we have to try to use topicals? Do we have to think about non-ingesting or non-chemical modalities, such as body work, such as trauma work? This can be really difficult and really hard to find what is actually needed to calm the system, but it can be done. The middle of the road patients, we can be a bit more methodical with this. We can go through a calming treatment, and if it doesn't work, we can move on to the next one, and then move on to the next one. With the sensitive folks, we can't really make a lot of mistakes. Patients are already coming in so sick, and if they don't tolerate a certain treatment, then oftentimes there's going to be a long delay before willing to try something else. There's several modalities again that we can go through, such as breathing techniques and meditation and energy work, and we can find those ways to calm the system. The robust patients in this situation for calming the system, we want to find out actually what is the problem here, and so the labs are very useful for robust patients, finding out what the reason why their body is so inflamed. And so sometimes treating that cause directly, we can skip several steps and move straight into actually treating what's needed. With the back to with the calming the system, we do want to think again about a route of administration, maybe adding tiny amounts rather than therapeutic amounts, and then slowly increasing with those sensitive folks. Next step would be allowing things in. This is where we want to create a flow state. We want to get the body ready to tolerate the next series, the next steps of treatment. This is where the collaboration with the patient is absolutely paramount. We want to set goals with the patient. The process is so important here. We need the patient to be very much a driving force in this step, because having empowered patients is really how they're going to get themselves better, and you're going to actually, as a provider, help facilitate them getting better. Setting goals involves looking at treatment arcs from a time standpoint, money, what kind of possible outcomes we should all expect, setting realistic goals, expectations, and costs, and time at that point is really a piece of it. Now, there are some supplements that can be very useful here. We may need to do methylation support. We may want to use minerals. We can use certain anti-inflammatory oils like palmitoylethanolamine or PEA. This is a good time for considering low-dose immunotherapy, low-dose antigen therapy, homeopathy, even things like oxytocin and low-dose naltrexone can really start setting up a scaffolding to allow the body to start feeling better. This is a pretty exciting step because many patients actually really start feeling better here, and so that we do build quite a bit of momentum at this stage. The goals are also to increase adrenal support for those people who can tolerate it, decreasing the neuroinflammation, stabilizing immune reactions, and then for all three groups is really getting a sleep pattern that's sustainable. Without sleep, very few patients are going to improve. The next step that I like to consider is to nourish the body. This is a very broad topic, but the idea is build the body up before we're going to have it go to war, as it were. We want to test nutrient status for many patients. We want to look at minerals. We want to look at amino acids and other nutrients. And to the extent that we can, is we want to replete those. This is also a really significant time to evaluate, treat, and heal the gut, with the exception of actually heavy antimicrobial work. There may be some time here where you do some antimicrobials just to get the gut functioning properly. But in general, this is a time for butyrate, for probiotics, for all of the other agents that decrease inflammation and increase absorption and help increase the absorption. And there's also a time here for minerals, for IVs, for peptides, as far as amino acids. I'll often use IV intravenous amino acids at this point, if for those folks who need it, and really try to help them get nutritionally replete from a mineral, from an amino acid, from a vitamin standpoint, and oftentimes from a calorie standpoint, using protein powders of various kinds, etc. There's also a time here to use hormones and that are where people are deficient, and maybe even for human growth hormone and analogs. The next step that I like to consider is restoring immune function. Many of these patients who present, their body overreacts. And the reason I think that it overreacts is because it's underperforming. And so if we could get the body performing more efficiently, it probably won't overreact so much. Many of us have found this over decades of work, that if we can help potentiate normal immune function, the overreactivity, which is often a compensation for underperformance, is not going to happen as much. So we want to look at mast cells. We want to, and many patients present with a mast cell activation syndrome, where some of their allergy cells and analogous cells to allergy cells are being proliferated for really no good reason, that assists the body. So there's lots of treatments, both herbal and homeopathic, functional, as well as pharmaceutical for mast cells that many of the doctors employ. We want to think about the different kinds of immune stimulation. Do we want to help stimulate the immune system? Do we want to help modulate and decrease the immune system? In order to do this, like I said, there's medications, there's supplements, there's uh, microbiome support, and there's even things such as gamma globulin, which can be done intravenously or can be done subcutaneously. There's lifestyle practices such as the Gupta method and DNRS, among others, as well as meditation and deep breathing and many other lifestyle practices that I discuss in my book, The Order of Treatment, that describe forms of restoring immune function. Next step is really to prepare the body for that antimicrobial push. Do that by cleaning up the terrain as best as we can. There's several different kinds of debris or toxicants, which are environmental agents. There's toxins, which the body makes, and then there's toxins, which the organisms, when they are dying, actually will create as well. So we have several different kinds of debris, whether it's from food or the environment or from cells or mycotoxins, pathogenic bacteria, et cetera, that we need to work on. And we don't have to completely detox people, which doesn't make a lot of sense if we're going to put in a bunch of toxins with antimicrobials to completely detox them. We'll just have to do it again, but at least to get them to the point where their body is ready to start going through a killing process. For sensitive patients, this can take several months and can be ongoing for quite some time and be the longest burden of treatment. Average patients, typically about 6 to 10 weeks, and then robust patients, often 2 to 6 weeks before we actually go with that antimicrobial push. This could include binders, different kinds of drainage, modalities such as sauna, exercise, lymphatic drainage, ionic foot baths, colon hydrotherapy, enemas, juice fasts, glutathione, phosphatidylcholine, phospholipids, baths, and then full mold detox treatment. Okay, then my favorite part, the killing of organisms that shouldn't be there. There's several different ways to do this. There's no perfect way to do this. In general, we obviously want to know what we're treating, especially when we're using pharmaceuticals. We need to know what we're treating. When we're using herbals, when we're using homeopathics, when we're using other modalities, sometimes we're going to cover various viruses. We don't need to know all the time exactly what virus. We don't need to know exactly what bacteria when we're using certain herbs that may cross over and cover Lyme and cover Bartonella and cover chlamydia pneumonia and mycoplasma pneumonia. Sometimes it's easier to use herbs, but in order to debulk many of these infections, especially the ones that patients are presenting with, we need to know what we're treating specifically and do this for a circumscribed time and then move on to the next one, and often going back to the first one. So in general, I'll typically start with big things. I'll start with worms, gastrointestinal worms, helminths, roundworms, flatworms, and then often go to amoebas, and then move on to many of the tick-borne infections that I know and want to work against. And in that general order, I'll work on Babesia first, unless someone is really presenting with Bartonella symptoms. Then I'll do Bartonella. Bartonella is tricky these days. Bartonella, it may be one of the harder infections to treat. Babesia is, there's general theories that if we work it into a corner and keep the pressure on and stack treatments up against it, that we'll have a better time of things. Whereas with Bartonella, One, maybe because it divides so rapidly and develops resistance and also works within biofilms, we have to switch drugs up or treatments regimens up more regularly than we would with Babesia, which we can often use by just adding new things. So I'll typically start with Babesia treatment after I've dealt with the parasites and dealt with the yeast. And I'll have to go back and probably deal with the yeast, but I'll do the Babesia first unless someone is presenting with florid Bartonella symptoms, which many other speakers I'm sure will talk about, and happy to answer any questions on those symptoms. Followed by Lyme, and then work alongside maybe on viruses, maybe on mycoplasma and chlamydia, and then go back to fungus, because we're often going to create fungal blooms by just treating many of these organisms. Lots of ways to do this. Again, there's modalities such as hyperbaric that seems to work for Lyme, often with antimicrobial treatment. There's obviously things like hyperthermia treatment that only really seems to work for Lyme, not so much for Babesia nor Bartonella. But the mainstay of this treatment is antimicrobial chemicals, whether you're using pharmaceuticals and groups of pharmaceuticals for Babesia and Lyme, dapsone and disulfiram, versus double intercellular antibiotics for Lyme, such as the tetracyclines and macrolides, plus a cyst buster with either your flagyl tindamaxilinia, et cetera. And then Bartonella, there's a whole host of other treatments that we use either alongside our Babesia and Lyme treatments. A lot of this has to do with the tolerance and what kind of patient we're dealing with, whether they're sensitive or robust. Much of it's described in the forthcoming book. But after that killing process, which could go on, the time is variable, so there's not really a timeline for that. But as we start getting people, they start getting themselves to about 65% of wellness, which we should do after several months on this process. That's when we want to start thinking about the maintaining and sustaining. Part of it is just dealing with Herxheimer reactions. Part of it is dealing with the other pathogenic organisms. And then sometimes going trolling for other infections. When people are in this routine and they get on this slope of improvement, sometimes that slope of improvement, where improvement over time, it starts to flatten out. And while we don't want to necessarily steepen it too much, because we can get into trouble if we try and go too fast, if it really starts to slow down, if their improvements and perceived benefits are really slowing down, that's when we want to start trolling for other organisms, trolling for other things. And this is nice, where we start using things like LDI, we start using other herbs, we start using a few things as provocational agents. We can even, this is also a good time to start looking for heavy metals if you haven't done so already, or even treating for heavy metals, going back and looking at some of the things that we had seen earlier in the course of disease. But it's eliminating and exploring and eliminating some of these hidden pathogens, detoxifying the body from heavy metals, which I don't think is a great idea to do before antimicrobial treatments. Working on maybe things like glyphosate and other environmental toxicants, revisiting some of the detox things that we did in step 5, doing them again in step 7, a little bit more completely, getting people we're really working on pushing the momentum here as well, because things can stall with the antimicrobial phase. When you're treating and you're treating and you're killing, it can seem to go on forever, and we don't want it to go on forever. We want to increase the momentum at this time. And a good way to do that is to actually reset goals, to re-establish what we likely can achieve and how to do it. And so this is a really good time to talk about dietary, other saunas, kinds of body work, doing energy work, cultivating a wellness mindset, getting ready to be well, because this is a time going from 65% to about 90-ish%. That's the goal of this phase, and that's the general expectations of this phase. there's oftentimes, this has also been a time for a more immune support, using some of the gamma globulins, using colostrums, and using other things for enhancing immune function. It's oftentimes, if I get people who I've been treating fairly aggressively with antimicrobials and seems like we stall, I'll evaluate them for ability to tolerate gamma globulin and maybe increase that. And sometimes that can be the lifesaver to get people completely over the hump. The Let's see, and then a big piece of this is attitude, is starting to think about wellness as a completely. Okay, the last phase is rejuvenating the system. Rejuvenating the system, it's kind of your wind down phase. This is where we should be at 85 to 90% of wellness. This is where we start doing, we start changing into a pulse of treatments, really starting to gradually take the medications away. We start optimizing mitochondria. We break out actually of the illness mode and start thinking more of a wellness mode. We want to increase autophagy here. This is a time maybe to start using things like fisetin and rapamycin and some of these things, decreasing oxidative stress, and using other modalities sometimes as we're kind of winding down. A lot of regenerative therapies take place here, mitochondrial supplements, magnesium taurine when there's some fatigue symptoms, doing laser, LED. Vasper is an amazing device, which is cold compression under exercise, so you don't get the lactic acid buildup and you don't get fatigue, but you build growth hormone. This is the phase which becomes a lifestyle change. You move from illness to wellness. There's many iterations of this, and again, taking into account there wasn't enough time obviously to describe all of the idiosyncrasies of doing this with the sensitive, middle of the road and robust patients, but knowing that people can move from becoming sensitive to middle of the road, from middle of the road to robust. Oftentimes when we get to this point, people are not so sensitive. There are times when of course people are, and they're still getting better, but remain in their sensitive state. But each group is different, needs to be managed individually. I think I can open it up to questions at this point. Thank you.
All right, Dr. Harris. Let's get rid of your share screen so you can stop sharing while I get to the questions here. Perfect. How has spike protein exposure changed the chronic Lyme landscape?
Well, I think philosophically, I think it's brought a lot of other healthcare professionals and healthcare systems on board. Just looking at this paradigm of chronic illness, it's many of the Lyme docs and functional medicine docs have been thinking in these terms for years. But with spike protein, it's very similar. It's a very similar concept to that of chronic Lyme. Of that, is there purely an autoimmune post-infectious driver of disease? Is there still infection? And so I think what it's done is it's brought research dollars, and it's brought very broad thinkers into this field, trying to find as many mechanisms for stopping illness as possible. There's Dr. Patterson's work, among many others, is trying to look at some of these autoimmune or hyperimmune, probably more hyperimmune responses to illness. And it's the same concept that many of us have been using. So it's nice that the field is finally expanding, and we'll definitely, as Lyme docs and functional medicine doctors, benefit from this process.
Is there anything specific that makes a patient sensitive versus middle of the road or robust? Is, if not a specific reason, are you seeing any trends?
So I think that genetics has a lot to do with it. Epigenetics probably has more to do with it than genetics. Epigenetics has a lot to do with life experiences and families' lives experiences. Uh, so environmental exposures, in addition to the genetics, the burden of disease, uh, the uh, the way that I think that we culturally respond to disease, the treatments that we've had over the years, our scars, our injuries. So I think that all of those are important. I think that we don't have enough answers, obviously, yet, and I'm hoping uh, with AI that we're going to be able to make many more correlations than we've had before. Those are the trends that I've seen. But I expect that we're going to get much more real-time data over the next several years to find out who and why some people are so sensitive.
All right, I see hormones are in your last stage. Does this include hormone replacement therapy? And if so, why would this not come earlier?
Well, it does come earlier. It comes at most of the stages actually. And the hormones in this phase are things such as more rejuvenation hormones, more things like the uh, the uh, ipamorelin, tesamorelin, growth hormone analogs and receptor analogs, things that increase the length of telomeres, the things that are increasing survival and cell survival. So most of the hormone therapy that I'm discussing in stage 8 and even a little bit in stage 7 is more of some of these rejuvenating and life extending hormones. Even things like VIP spray could go into that, although we usually will have done things like that vasoactive intestinal peptide earlier on. There is also time during this rejuvenation phase where things like that can be really useful.
Did I hear correctly that you recommend mitochondrial support later in the protocols? Some practitioners these days are recommending mitochondrial support earlier in their protocols to give the patient enough energy to move forward with other components of their protocols. What are your thoughts?
Well, my thoughts are several. I think that many times, depending on the presentation, with fatigue, for example, we're going to do also as part of stage 2, as far as allowing things in, mitochondrial support can come in even there. If we can help people have more energy, then it's going to make everything easier. It's going to help the body get nourished better. It's going to even help with the immune support. It's definitely going to help with the tolerance to the antimicrobials. So there's actually, yeah, I oversimplified, but I do use and believe that mitochondrial support can often be done at many stages of the way. I think that it sticks the most after the killing phase is over. I think that the maintain and sustain, particularly, uh, and sometimes in the rejuvenation phase, but the maintain and sustain phase is really where many of those many of those mitochondrial support therapies are going to last and be much more functional, whether you're using things like PQQ or even CoQ10, which I'm sure we will have used along the way, the carnitine and the other mitochondrial supports, the magnesium, taurine, and such, and many other these modalities. So we're always trying to find a way in, and if there's times to use it, by all means, we can do it at many other stages besides the end.
What is the efficacy of antibiotics for Lyme, Bartonella, and Morgellons? If so, which and what is the duration? Some people take them for life, it seems.
Okay, so Morgellons is different. Morgellons, I don't know how long we often have to treat because many of my Morgellons patients, we've had to continue treatment to some degree with some breaks. And so with Morgellons, I'm typically going to pulse antiparasitics with some antibiotics, uh, and I'm probably going to do that open-ended. The general rule that some people started a few decades ago is that you treat past the resolution of symptoms or until you get to a plateau for 2 months or so on treatment. The treatments for Bartonella range from, I mean, 4 weeks at the very uh, least to ongoing, often retreating. I don't always treat people and don't like to treat people straight through, even for Bartonella all the time. I think that the tolerance has so much um, to do with the staying power and maintaining your ability to keep on treating. So I would say that if someone comes in with, I'm going to table the Morgellons question here for a moment, but if someone comes in with symptoms and validation of Babesia, Bartonella, and Lyme, whether or not they have anaplasma uh, or Ehrlichia, because we're probably going to treat them while we're treating these, unless they're really presenting with those symptoms. I'm looking at typically about 15 to 24 months, not straight through necessarily, but about 15 to 24 months is about the length of time that I would expect to treat someone who, and this is for people who have been sick for probably more than a year. If it's less than a year, then it's going to be less than that, generally, with some exceptions. But I'm expecting upwards of 24 months. I do find that one of the reasons I had to become a functional medicine doctor is that the antibiotics, the pharmaceutical antibiotics, weren't enough. They weren't getting deep enough. They weren't being efficacious enough for at least 30%, probably now more of people. So whether we're using other modalities to draw biotics in, whether we're using biofilm treatments, in addition, where we're using things like the oxygen and the heat and plasma exchange, even just to get a clean slate, getting rid of some of the immune complexes and such, and then going back in with pulse targeted treatment. If we do it thoughtfully, we should be able to do it in 24 months. Now, the problem is, in reality, is that people do get treatment fatigue. They do get toxic to meds. They have issues with tolerance. And some people also, and it's a real piece of it, and it really needs to be discussed and thought about, is the knowing the devil that you know versus what you don't. So some people find that if they're 75% of wellness, 80% of wellness, maybe, or that they know that they're functional on a certain treatment, that that's what they prefer over a um, complete eradication strategy. We can't prove eradication. There's no tests that really can prove it in adults. I think with children, it's very likely that we're going to completely eradicate the infection. A lot of times, what we're shooting for is to knock the infections into dormancy, utilizing the immune system to take over. We get people to 90%. A lot of time, at least debulking the infection 90% or so, we're probably going to get the immune system to do the lion's share of the work after that. That's often the goal, but these are really important considerations that one has to make with their provider, with their loved ones, about, do I want to? Yeah, so much of what we do is looking at the symptoms and treating based on symptoms, because we don't have enough good real-time tests to tell us exactly what we're dealing with yet. So when we're using symptoms, if someone comes in and they have some mild symptoms that they can deal with or they can live with, are we really going to use like a Zhang protocol with ibidaptomycin and doxycycline, yeah, and a cell wall drug, NBANs, for example? Are we going to really use like a triple IV therapy? Are we going to use disulfiram? Are we going to use high dose, double dose dapsone, what have you, to treat that? If there's a lot to be said to it, but yeah, I'd say 15 to 24 months is what I'm really shooting for. Hopefully, some of these new therapies, especially the dapsone therapy is with the high dose methylene blue and such, will shorten that without causing other problems.
How would one know the severity or extent of how much biofilm has accumulated to know how long one's doctor should be trying to hack away through the layers to expose the spirochete? How long they treat us for, and how important, and most importantly, how to know the job was done and it's time to stop treating?
Well, I mean, look, we have some labs that give us a sense. There's T lab, there's other labs that do hint at biofilms, volume, quantity, etc. But I think so far for me, the best way that we can do this is with some of our known biofilm treatments is pulsing a treatment, watching a symptom change without making other changes. So being as scientific as we can about it, but utilizing that clinical experience of the provider and using symptom changes to really evaluate that. Now, it's not perfect, and I do think that biofilms are such a hot topic that we're going to get quite a bit more over the next probably 5 to 7 years of really being able to answer that question. Because right now, yeah, we're generally running blind about how, when we're done with it, because there's been too many times where we think patients are done with treatment. They have no symptoms. 2 years later, something changes with their immune dynamics, car accident, root canal, baby, anything, and then symptoms come back. And the only way they probably came back was because things were stuck in biofilms. I mean, sure, there's cyst forms and dormant forms of that, but a lot of this is biofilm related. So no, it's a good question, and it's one of the things that I don't think anybody can give you an honest answer to for being right. And if they do, would love to meet that person. We got time for one or two more.
Okay. When someone has autoimmune conditions, in addition to Lyme disease or infections, does the experience and treatment process have more surprises and hiccups? If so, how do you prevent those from arising while addressing the Lyme and its co-infections?
Great. And then very involved question. And so I would start it with that I do feel that there are many situations, and not all situations, many situations where the body is trying to do the right thing. It's just not able to do the right thing. And then there are some few times when the body is just completely reacting to itself. Usually the body is smart enough and has enough survival genes, I guess, as it were, that most of what we consider autoimmune is hyperimmune to something that science hasn't figured out yet. And I think that that's the case for the majority of multiple sclerosis. Multiple sclerosis is an autoimmune condition after everything has been ruled out. Well, when do you stop trying to rule things out? Rheumatoid arthritis is an autoimmune condition after everything has been ruled out. So Behçet's syndrome is a very dangerous autoimmune symptom after everything has been ruled out. Lupus erythematosus is after things have been ruled out. And we know, like in the case of lupus, for example, that and in the case of Lyme, that there are bacteriophages that are meant to infect the Borrelia organism, but actually can carry the complement of the Borrelia organism, go into our DNA, slice, put in some Borrelia DNA into our genome. We make antibodies against that double-stranded DNA called lupus. is it really lupus when the body's actually making antibodies against DNA that shouldn't have been there of ours in the first place? So yes, we have to be careful with this. And I think that, especially that we can get drug-induced lupus. And so there's definitely drugs that I'm going to be really nervous about putting people on that if they already have an autoimmune presenting condition. So I'm going to be very careful with the agents and the combinations of meds that I'm going to do. But I'm also going to be kind of in the back of my mind sometimes, wonder if this is more of a hyperimmune condition rather than autoimmune. Obviously, there are many cases where we need to suppress the immune system in order to go ahead with treatment, whether it means using, our rituximab or, our Janus kinase inhibitors or our TNF alpha blockers and our steroids even that there are those situations where we want to do that. There's also other modalities that we can sometimes do. And so, yes, going to be more careful, going to work on push detox quite a bit more in those folks. And I am going to definitely treat them gingerly, and work up slowly in those folks.
Okay, we'll do one last question, Dr. Harris. Does your approach to phases and or to speed in moving through the phases change if the patient has very advanced chronic Lyme and co-infections?
Yes. So those phases they're rough phases. There's a few situations where I'm going to skip it all, right? Typically, someone has Lyme carditis, and if they're like we had a patient, I don't know, 12, 15 years ago, Lyme carditis. We went straight to IV antibiotics with him. We didn't mess around with anything before that. We worked on detox, of course, and as we needed to, but we did IV antibiotics and hyperbaric oxygen, and he was able to regain his health. With patients who have advanced Lyme that's presenting, it really depends on the manifestations, I guess. So someone comes in presenting with an ALS or PLS or MS or Parkinsonian or dementia, and if we cause a HERX, if we cause a bad die-off, they have a hard time coming back from something like that. So in those people, I'm gonna try to, depending on where we're, on how dire it is, I'm going to try to do it in a way where I can hedge, where if we go too far, we can step back, but at the same time, trying to front load some of the things that are going to help people feel better. So it's such a variable question. I mean, I could probably answer that 1,000 different ways, but it depends on the presentation, I would say, and it depends on how much time we have before there's no going back from it. Sometimes if people, are on a feeding tube because they can't swallow because of their level of motor neuron disease, then we're going to do whatever it takes. And I think the important part is that's where those managing expectations comes in, discussing of resources, because we do see people who come in and they're deathly ill with advanced motor neuron disease or advanced dementia, and they definitely have Lyme, whether it's PCR culture, whatever, positive, fish positive, et cetera. For Babesia and Bartonella, and we know that they have the infections, but and a lot of times the families are like, we'll do anything to, don't stop. That you're looking at, thousands and thousands of dollars and sometimes an unlikely chance of success. So I think it's really important to have very significant, heart-to-heart conversations about goals of treatment and managing expectations there.